For the first time, the Agenda for Sustainable Development recognizes migrants, refugees, and displaced persons as vulnerable groups and calls for full respect for their human rights. It recognizes the positive contribution of migrants for inclusive growth and sustainable development. It calls to achieve UHC and equitable access to quality health services, to leave no one behind. To achieve the SDG 2030 on UHC, the health aspects of migration must be addressed, and this technical briefing is an important step along that road. My name is Ed Kelly. I'm the Director for Service Delivery and Safety. I'm the facilitator here and occasional comic relief perhaps here and there, but I'll keep my remarks to a minimum. I would only mention a couple of things, just housekeeping, before I turn it over to our illustrious guests who will open, our own Director General Margaret Chan and Ambassador Bill Swing from the IOM. I'd like to turn the microphone over to our Director General, what will be followed by two panels of country presentations. And you'll notice some musical chairs so that we can accommodate everyone and have them move up and move back down. But without any more introduction, DG.
Thank you, Ed. Good afternoon to all of you, and it is such a great pleasure to see so many of you here. Distinguished panel members, all protocol observed, and of course, all my bosses, ministers of health, distinguished delegates, civil society colleagues, and many others. Let me, very happily welcome my brother, Bill Swing. And he's the head of a very important organization, which, I better not tell the secret yet, which will soon be part of the UN family. Isn't it wonderful? Good. And we know for a fact that countries who are, shareholders of both organizations like us to work closely together. And that's exactly what we are doing. And welcome, very warm welcome to you, Bill. And of course, I'm happily joined by Dr. Susanna Jacob, the Regional Director of the European region, who has been very active in the region with the countries, particularly countries like Italy and Greece, and I'm sure they will share with you their experience. Without further ado, I would like to say a few words and stay for as long as I could until my bodyguard tells me, get up and go. And because I need to roller skate to other events, and this is the exciting part of World Health Assembly. We have so many side events, and they all want me to be there, to be a cheerleader. That's exactly what I will do here. Now, migration and health is a global issue. In a world that is increasingly defined by vast inequalities in income levels and opportunities, migration is a fact of life. People will always migrate to places that promise a better life for themselves and for their children. There's nothing wrong with that, right? It's just human nature. But what we are seeing now is forced migration. There is a difference caused by armed conflict and violent extremism. War-torn countries are emptying on the one hand. Their generous neighbors are saturated. For example, in the case of Lebanon, Jordan, many countries in the neighborhood of Syria. Ladies and gentlemen, the 2030 Agenda for Sustainable Development recognizes migrants, refugees, and displaced persons as vulnerable groups and calls for full respect for their human rights. Let me outline 4 urgent needs. Number 1, we need better data on the health needs of migrants as a foundation for setting policies and priorities. Migrants travel with their health profiles, which mirror the health conditions and diseases in their countries of origin. Health problems can also arise from the stress of travel, right? Whether you walk across the land border or you need to get on a boat, sometimes the journey is quite risky, and many people pay the ultimate price for taking those journeys. And if you survive, can you imagine the stress? The stress. It's amazing. So health certainly need to look at the stress, not only their health conditions, but also look at when countries who receive them, be it transit country or recipient countries, whether they are living in the right kind of conditions, not over too crowded, and then with no guarantee of safe food and water. So some of these are challenges we need to address. Now, the second thing I think we need to address is we need policies and legal frameworks in recipient countries that guarantee access to healthcare in an integrated way, the policies that keep migrants in camps and deal with their health needs through a separate mechanism or service provider contribute to marginalization. And we have learned from recent examples, marginalization will give you problems as well down the line. So it is important that we need to, at the outset, in formulating policy, to take a longer perspective and what would be the consequences of your policy. The third thing we need is migrant-sensitive health services that are culturally and linguistically appropriate and recognize mental health needs. Last but not the least is, of course, collaborative networks and international dialogue, as we are seeing today. And in this lunchtime technical briefing are essential, because your input, your advice, and your experience would be amplified through UN agency and other organizations, so that governments can put in place the right kind of policies within the means they can do so. And of course, development partners also need to help countries who have been very generous in accepting migrants and refugees. So let me once again thank you for being here, and thank you for sharing with us your rich experience.
Thank you so much, DG. And as is my case, I'll just keep talking. And then if there's at any point you need to tell me to stop talking, you let me know. But I would then introduce Ambassador Swing, who's graciously joined us. And the IOM has been a real partner in the preparation for this. And Ambassador Swing's team, Davide Mosca, Jacqueline Weekers, and others have really worked with us on this. But Ambassador Swing is Director General IOM. He was UN Special Representative for the Secretary General for the Democratic Republic of Congo, 6-time ambassador, and a deep understanding of the multiple factors affecting international migration through his diplomatic assignments in countries facing significant migration movements. So Ambassador Swing, the floor is yours.
Thank you very much, Edward. It's indeed a great honor and joy to be with you today, to be included in this august gathering today. I'm particularly honored to be in the presence of my considerably younger sister, Margaret Chan, who's a great force for health globally, but is a very great partner of ours as we've worked collaboratively and closely in trying to make sure that migrant health stays on the agenda if we're going to talk about universal health. So I'm extremely grateful to the Director General for her support and close collaboration. And in our various trips where we've met up in airports and conferences, we've enjoyed it. We've enjoyed one of those companies. So it's great to be with you, Margaret. I'm really grateful for that. It shows the importance that both of our organizations attach to the whole issue of migrant health. And you know, we try increasingly to help countries to see migrant health as something that's in the national interest. The very simple question, I'm always being educated by my colleague, the head of our Migrant Health Division, Dr. Davide Mosca, who's with me, that do you really want unhealthy migrants in your communities? Would you not rather have a healthy community that wasn't threatened by an unhealthy migrant? Wouldn't you really want migrant children to be educated? Do you want them to be analphabet and uninformed and unable to make the contribution that migrants have historically made? So I think it's fairly straightforward, and sometimes I wonder how we get ourselves tangled up in this question of whether access to public health for migrants, whatever their category, is this something that the state should allow? Isn't it something in the state's interest? So I'm getting a little bit ahead of myself because I want to start, first of all, in addition to thanking Dr. Chan for the close collaborative and long-standing relationship we have. We're next door neighbors as it stands, and I don't want to move out of that building because I like my neighbors. We also have ILO across the street. So I'm glad for this opportunity. I also want to recognize my colleagues, the Regional Director for Europe, who we met with before, and of course Stephen Corliss from our traditional, long-time, 65-year partner, UNHCR. And I want to recognize the governments of Costa Rica, Liberia, Sri Lanka, Thailand, Greece, Italy, Lebanon, and Turkey in particular, but all of the other countries that are represented here today who support an equitable migrant health agenda. This is one more step in building that community of support. Like Dr. Chan, I want to make 3 points. I want to point to 3 realities, if you will. First of all, as was already said in her introductory remarks, we're living in a period of unprecedented human mobility. There have never been this many people on the move. I thought you were raising your hand. You were taking a photograph. We've also never had as many people forced to migrate. We have what I call the 6 Ds. We have a demographic deficit in global north and a demographic surplus in the global south with a turgid rate of job creation. So all of our societies are going to become inexorably more multi-ethnic, more multicultural, more multi-religious. And if governments are not informing and educating their publics about this, it will not have a happy ending. We also are in a period frankly, of, I would call it the digital revolution. 300 million people connected to the internet in the year 2000. Today, it's gone beyond 3 billion, heading toward 4 billion. So information is out there. We have distance shrinking technology. We have the whole question of the degradation of environment and climate change. All of these are driving forces that means that more people will be on the move. So therefore, we have to look carefully at the nexus between health and migration, health and migrants. I think that also all of these people, as the Director General has already mentioned, they all have physical and particularly psychosocial needs that must be addressed if we're going to have very, very good, healthy communities. So my second point is to say that we have currently to deal with a toxic public discourse on migration. Migration has become a negative word, if not a dirty word. And the cruel irony of this is that people who are fleeing the 5-year war in Syria, problems in Yemen, in Libya, South Sudan, Central African Republic, Boko Haram in Nigeria, and perhaps some that I missed, these people are now being identified in the public mind through this toxic discourse, somehow or other with the very terrorism and threats that they themselves are fleeing. So we have to get back to a much more historically correct narrative, namely that migrants have always contributed overwhelmingly historically to development. I've never understood the New York debate, maybe because it's in New York. Of course, I come from the South, but I also live in New York right now. So this discourse between migration and development, does migration contribute to development? You're discussing that in one of the world's most integrated migrant communities, New York City. I don't understand it. Of course they contribute to development. So we need to get back to that discourse and say that somehow we've got to come out of this situation where migration is no longer viewed as a positive force in our lives and advocate for a comprehensive healthcare system that includes migrants, whatever their category. Whether they're with legal papers or not, they will have needs, and it's in our interest to help them. And the final point is just simply to say we have to have more action to ensure migrants' right to health, to see that that is respected, and that universal health services include migrants as well as all others. We do it for 2 reasons, 2 major global health goals. First of all, we've got to reduce the disparities that create and sustain adverse health outcomes. And secondly, this is subpoints under my final point, programs that are designed to manage or mitigate the global spread of disease. What we discovered with Ebola, what we're discovering with Zika, is that mobility is a major element to be considered. This is why we were managing emergency operations centers on the border with Guinea. This is why we were working with the Ebola Training Academy in Freetown, Sierra Leone. This is why we were helping with partners to put up the first Ebola treatment units outside of the capital, Monrovia, because we have to recognize there is a mobility factor, and it's in our interest to be in touch and to help people address the problems before they spread. So let me with that stop, and I'm looking forward very much to learning a lot here today from several distinguished panels here, distinguished panelists. So thank you very much again for the honor of being with you.
Thank you so much, Ambassador Swing. And can I note, although the ambassador and I come from the same country, my own family migrated from his part of the country, where we spoke properly and slowly, up to New York City, where we speak too fast and we're very rude. So I'm very sorry for how fast I'm talking, translators. So, but I'll continue because that's the only way I know how to talk. As someone who's been at the very center of this discussion for WHO, it's my really great pleasure to introduce Dr. Susanna Jakob, who's the WHO Regional Director for Europe. She, as many of you know, previously served as the founding director of European Union's European Center for Disease Prevention and Control in Stockholm, Sweden, and between 2005 and 2010 really built ECDC into the institution it is. I can, because none of the other RDs are here, I can say she's my favorite RD because she has also championed universal coverage and the Euro framework on integrated people-centered health services, which finally headquarters has caught up to Euro and is adopting just later today a global framework on the same topic, which is extremely relevant to all that we just heard. So the floor is yours, Susanna.
So thank you for the nice introduction first and foremost. Director General, Ambassador Swing, Excellencies, ladies and gentlemen, it's a great honor for me to be part of this panel discussion and talk to you on this very important issue of migration and health, which is really a worldwide phenomenon and which quite often challenges the well-established values and principles in our work. And the 2030 agenda, the 2030 agenda, leave no one behind, will only be a meaningless cliche, as the UN Secretary General says in his report. If we do not strengthen our common response and agree to new global commitments, which respect the human rights, safety, and dignity of migrants and refugees. And of course, this also applies to health, and there is an urgent need for a coordinated response to health issues, which is a key both for the migrants and refugees, but also for the population health overall. So until the slides are on the screen, let me say that already in 2012, the Regional Office for Europe of WHO started a joint work with the European countries, funded very generously by the Italian government, to assist member states in adequately responding to the public health challenges emerging from migration and to protect the health of refugees and migrants and the host population. This work was around four major issues: information, policy development, technical cooperation, and advocacy and communication. And then the work was scaled up in 2015 and added two additional components: to deliver medical supplies and to organize training workshops. Our aim is to guarantee and to provide the necessary capacity and guarantee adequate standards of health and well-being, both to the migrant population and also the population overall. At the request of the health ministers at the last regional committee meeting, we organized a major event in Rome last year with the participation of 50 countries, both from the European countries, but also Eastern Mediterranean region and African region. And all these three regional offices were present, and so was headquarters from WHO and all the UN agencies and international organizations. And this meeting, which was very successful, it ended up in an outcome document, Stepping Up Action on Refugee and Migrant Health. And in this outcome document, the member states agreed that these public health implications of migration requires a concerted and coordinated response in the spirit of solidarity and humanity. This is essential both for population health as well as for human right of health for all. Public health interventions are needed both in the long and also in the short term, with special focus on the most vulnerable. This also acknowledges, this outcome document, that we need to strengthen national, international, and intersectoral collaboration, and we need to build bridges of collaboration between the countries of origin, transit, and destination. And European countries also agreed on the need to strengthen coordination among the UN agencies and other international organizations. The Rome meeting was a milestone in our region, and it was also an excellent example of interregional collaboration to address global health issues that transcend countries and regions. And it proved that countries within and beyond the European region are willing and committed to collaborate on migration and health. This work is now going ahead, and we have developed a strategy and an action plan with an accompanying resolution, which will be submitted to our regional committee this September in 2016. And this might then lead the way also for similar global developments, because as the DG has pointed out, migration is a global issue. As migration and its health implications will stay with us in the years to come, a consensus is emerging that migration policies at global and regional levels will be important to ensure interstate collaboration, as no country can manage these issues alone. Following the Rome meeting, we also organized a meeting in Copenhagen with all the UN agencies, where partly we asked their input into this emerging strategy and action plan, but we also identified some common objectives, synergies, and joint initiatives to strengthen international collaboration in this area. And now we are in the process of organizing a joint meeting between the European region and the Eastern Mediterranean region, an interregional technical meeting to strengthen the collaboration between the two of us. I am also extremely grateful to announce that the Italian government agreed to continue with its funding for the second phase of the project, and a knowledge hub is also being established in Sicily on migration and health issues. Of course, the European region is not the only region that works on this. All the other regions are very much involved. In the African and Eastern Mediterranean regions, emergency response and humanitarian assistance have been provided to support countries in new and protracted emergencies for both refugees and internally displaced persons, such as in Syria, Lebanon, Jordan, and Sudan. In the Southeast Asia and Western Pacific countries, universal health coverage is used as an umbrella to meet the health needs of refugees and migrants. Regional collaboration includes the initiatives such as Healthy Border Program, with a focus on countries in Greater Mekong sub-region, which includes Cambodia, China, Laos, Myanmar, and Thailand, with particular emphasis on TB, HIV, malaria, and there will also be a review of access to services by migrants in this sub-region. For economic migrants, Sri Lanka has led the Colombo process with 11 countries in Eastern Mediterranean, Southeast Asian, and Western Pacific region for fair labor contractual arrangements. In the AMRO region, emergency response and humanitarian assistance has been provided, for example, in Colombia, to support emergencies for internally displaced persons, together with the incorporation of the human security approach in health plans of communities of destination. AMRO has also partnered with IOM to improve the health of children and youth migrating alone from the North and Central American countries to the United States. And overall, AMRO activities are based on the resolutions for the Plan of Action for humanitarian assistance, human health security, and universal health coverage synergies. Migration is a global reality which is caused by conflicts, poverty, inequality, climate change, disasters, environmental degradation, and you name it. While we address the immediate concerns, we must think longer term for the sake of migrants and host communities, address the root causes and also the solutions, and use the many positive examples that we are seeing across the world. In health, it is easier to find a consensus than in the other areas. And therefore, health can also lead the way for other areas, as it has done many times in the past. In this regard, there is no public health without refugee and migrant health. The health dimensions cannot be addressed with single country solutions, and within WHO globally, we must work with member states to achieve a number of policy aims, to reduce excess mortality and morbidity, minimize negative impact of the migration process on communities of origin, transit, destination, and return, avoid disparities in health status and access, ensure refugees and migrant health rights. Countries must develop inclusive migrant health policies, as Dr. Chan already pointed out, with a health component and also put it in practice. Health systems must be adequately prepared to provide universal health coverage and equitable access to quality health services. Migrants and refugees should have access to public health programs like immunization. It should also bridge a short humanitarian response with long-term development. Furthermore, countries must have adequate health information systems with robust epidemiological data on migration, careful planning, training, and above all, adherence to the principles of equity, solidarity, human rights, and dignity. Equally and finally important, countries should have coherent policies across various sectors as well as across countries involved in the migration process. This is our aim, ladies and gentlemen, in the work that we are doing within the framework of WHO, led by Margaret Chan and supported by all the regional directors. Thank you for your attention.
Thank you so much for that, Susanna, and for the excellent summary of across the regions, but particularly in Euro as well. We have been very pleased to also partner in the setting up of this discussion, but also looking forward to the many discussions coming this year on migration with colleagues at UNHCR and Stephen Corliss, who is Director of Division of Program Support and Management with the Office of the United Nations High Commissioner for Refugees in Geneva, has been able to join us here today. I understand it's a particularly risky session for you because there may be some friends in the room here, so you better perform very well. So anyway, but over to you.
Thank you very much, Chair. Honorable Ministers, Ambassador Swing, my UN, WHO and UN colleagues, civil society colleagues, ladies and gentlemen, and distinguished delegates. I'd like to thank WHO for inviting UNHCR to this technical briefing on migration and health. I'm sorry that Dr. Chan wasn't able to stay because I think she would have heard some echoes with her introductory statement. Let me start by being very frank. We're talking about refugees and migrants this year at the World Health Assembly because more than 1 million of them came to Europe in 2015 and 2016. The Syria crisis has been on Europe's doorstep for 5 years now, but last year it crossed the threshold. Refugees and migrants are a crisis for Europe, but this is a broader challenge. Globally, 86% of the world's 60 million refugees and internally displaced people live in developing countries. With the recent overwhelming focus on Europe, I was really pleased to see the diversity of the countries represented on the panels that will follow my presentation. Forced displacement has captured the world's attention, but this is not a new story. Sudanese refugees, they're now South Sudanese, first reached neighboring countries in the mid-1950s. Afghan refugees began entering Pakistan and Iran in 1979. The movement of Somali refugees also started in the 1970s and then accelerated from 1988. Millions of people around the world are born, grow up, go to school, get married, have children, become ill, grow old, and die as refugees. New conflicts break out before old conflicts are resolved. Peace, security, and the possibilities for solutions to displacement that they bring remain elusive. The sheer scale of displacement and the duration, often lasting for decades, mean that purely humanitarian responses to meeting the needs of refugees and the internally displaced are not adequate, effective, or efficient. For many years, UNHCR's approach, as Dr. Chan, I think, said, was to maintain refugees in camps, to meet their basic needs for protection, shelter, food, water, and health care, working with governments and our NGO partners. This does not describe the reality today, where more than half of all refugees live in cities. Let me tell you how UNHCR is changing its approach through our policy on alternatives to camps and our global strategy for public health. We're moving decisively away from parallel systems funded by UNHCR and implemented by our partners that work in parallel to ministries of health. Today, together with ministries of health, we're moving decisively toward more integrated and development-oriented approaches that reinforce and build upon national service delivery systems and healthcare financing mechanisms. Let me tell you about a few places where we are making this approach work. In Ghana, UNHCR and the Ministry of Health are implementing a 3-year plan to integrate refugees into national health services and the National Health Insurance Scheme. Similarly, in Egypt, more than 130,000 Syrian refugees have access to the same primary health services available to Egyptians at a nominal fee, as well as to free vaccinations and medications. The Islamic Republic of Iran and UNHCR have signed an agreement that will ultimately give access to over 1 million Afghan refugees to the government-sponsored Universal Health Insurance Program. And we're exploring how healthcare delivery for refugees in Cameroon, Niger, and other countries can be integrated into national systems. Working through national systems has the potential to be more sustainable, more cost-effective, while also ensuring more comprehensive coverage of all people living in the same area and the equity in the services they receive. Working in parallel to national systems is costly and it's ultimately unsustainable. It can undermine or distort national development planning. While I was working in Tanzania a few years ago, I saw a very fine district hospital in Ngara town that UNHCR had built with scarce humanitarian funds. It stood empty, with no staff and no budget, because it was off the radar for the Ministry of Health. I also saw huge gaps in healthcare emerge when refugees went home to Burundi, camps closed, and the clinics that served refugees and local people disappeared. We see the mainstreaming of refugees in national systems as the best way to achieve universal access and improved health outcomes for both nationals and refugees. The logic of integration is very clear. Preventative health care, such as immunization, as well as prevention in response to disease outbreaks, are most effective when pursued through a single, unified system. Put it simply, there are different needs refugees and migrants have. They need differentiated responses, but these can be delivered through one system. We do need your help to make this vision a reality. First, we encourage member states hosting refugees to consider the possible win-win opportunities created by integrating refugees into national services wherever possible. Secondly, we're asking WHO to work with the member states and support them in making the legal and policy changes needed to bring refugees within national and local development planning. Third, we call upon the member states to support UNHCR, that support UNHCR and provide development assistance to make the multi-year funding commitments needed to support change, commitments to governments, not necessarily UNHCR. And fourth, we're looking to the World Bank and other development partners to help us build the data and evidence base needed to support mainstreaming and provide the flexible financing that it requires. We do need to be realistic. Integrating refugees into national health care and national health insurance schemes, whether public, private, or public-private partnerships, will only work where these systems exist and are sufficiently robust to assume the added responsibilities. We're also clear that rapid, agile, and effective emergency response, sometimes delivered in parallel to national systems, will continue to be essential to save lives in emergencies. But longer-term planning for more development-oriented approaches must begin early. And I think I should add here that we really welcome WHO's review, rethinking, and possible reinforcement of its role in emergencies. We're convinced that mainstreaming refugees within national healthcare systems is essential to deliver on the promise of the 2030 Agenda for Sustainable Development, which is to ensure healthy lives for all and to leave no one behind. Thank you very much.
Thanks so very much, Stephen, for that and for joining us. Now, if I might, we've organized this session in two themes in terms of hearing from our colleagues from countries. First theme is on sustainable development and migration. And the countries in this theme include our colleagues from Costa Rica, Liberia, Sri Lanka, and Thailand. And the second theme will be on large-scale displacement. And the countries in that panel will include Greece, Italy, Lebanon, and Turkey, who have very graciously agreed to sit in the front row and have a nice view on the video. And then we will have a bit of musical chairs just while we switch. And in the interim, I can fully anticipate that there's much, much more to be said in this room during this session than we will have time to say. So every time we flash up on the screen that placeholder, there's an email there. We are taking statements from individuals, from organizations, to put in the official record. It could be the tweet that you like the most, if you like that, or it could be an official statement from your organization. I just think I will have a very difficult time finishing the day and getting back to our agenda otherwise. But so know that and write down that email when it's up there. But this theme that we're looking at now in sustainable development and migration will look at issues of economic migrants, both documented and undocumented. And economic migrants very often benefit both their country of origin as well as their destination country, and in terms especially of economic development. Many migrants, those undocumented, have no universal health coverage or equitable access to quality health services. And this panel will discuss key policies to address these issues as countries of origin and destination, as well as transit countries. And we'll look also at regional collaboration and partnership. And we're very much looking forward to the experiences and lessons to be shared. Our first panelist, who's very graciously agreed to go first, and it's a country that we work with a lot on this issue, I'm very pleased to say, is Dr. Fernando Yorca Castro, who's the Minister of Health, Costa Rica. He served as Deputy Minister of Health in August 2014 and became Minister in February of last year. So the floor is yours, Minister. And I'm sorry, Minister. With my sincere apologies to the Italian colleagues, I did not announce that we have Italiano is on channel 8 for anyone who is waiting for translation on Italian. So very sincere apologies. But to you, Minister.
Thank you very much, Dr. Kelly, because you brought all the translators here to I should speak in Spanish, otherwise everybody's going to ask why you brought the Spanish translators. Okay. So, es para mí un verdadero placer estar aquí con todos ustedes. Agradecemos muy especialmente a la doctora Chang, al señor don William Lacey Swim de la OIM, y es un gusto compartir panel con tan distinguidos ministros de salud, ministra de salud y representantes de organismos internacionales. Voy a compartir con ustedes la experiencia de Costa Rica. Es un país destino para personas de Centroamérica, esencialmente por razones laborales, pero también se ha convertido en una zona de tránsito de migraciones que provienen del Caribe, África e Asia inclusive, buscando el norte de los Estados Unidos. Costa Rica tiene una población de 4,5 millones de habitantes aproximadamente, y hemos documentado para el año 2011 que se efectuó un censo, esto no es una proyección, una población de extranjeros de 385,000 aproximadamente. El 75% de estas personas son de origen nicaragüense, que es el país vecino del norte, y como lo mencioné, la gran mayoría de ellos ingresan a Costa Rica buscando oportunidades de trabajo. Hay que mencionar que esta es una relación histórica. Hoy en día gran cantidad de la población nacional tiene ascendencia nicaragüense, ya que al nacer sus hijos en nuestro país automáticamente obtienen la nacionalidad, cosa que es un elemento importante a tomar en cuenta en todos estos aspectos de migraciones. Otro de las experiencias que hemos tenido histórica es el desplazamiento temporal de poblaciones indígenas que provienen de Panamá, poblaciones Nogbe y Buglé específicamente, para participar en la recogida del café, que es una de las actividades económicas agrícolas de Costa Rica. Y en ese sentido quiero rescatar aquí que hemos tenido una colaboración muy estrecha con el gobierno de Panamá, que en donde hemos mejorado mucho, y gracias también a la intervención directa de organismos como la organización, como la OIM, que nos ha ayudado muchísimo en este proceso, a quien reconocemos y agradecemos su colaboración, para, por ejemplo, desarrollar pequeños detalles que facilitan el tránsito de estos panameños a territorio costarricense, como lo es el desarrollo de un carnet de salud conjunto mutuamente reconocido entre los dos países. Históricamente se daban situaciones concretas como que se vacunaban a los niños en Panamá y luego al ingresar a Costa Rica se volvían a vacunar con el carnet de vacuna de Costa Rica. Hoy en día, gracias a esa coordinación, reconocemos la vacuna mutua de ambos países y pues los niños se salvan de algunos pinchazos. Hay que decir que otra de las experiencias más recientes que estamos teniendo en nuestro país, y como muy bien lo han señalado el interventor anterior, don Stephen Corliss, y también pues la doctora Jacob, el problema es un problema universal. Estamos recibiendo gente que busca los Estados Unidos y utilizan a Costa Rica como un puente migratorio. En color rojo, en color verde se ilustran las migraciones que buscan a los Estados Unidos, y a nivel regional existen, ilustradas en tono amarillo, pues distintas migraciones históricas de un país vecino al otro, esencialmente por razones laborales, como decía. Costa Rica tiene una legislación muy definida, tiene una ley de migración que constituye un Consejo Nacional de Migración que es intersectorial, tiene representación de la Cancillería, de Migración, de Aduanas, del Ministerio de Salud, de Seguridad y de, por ejemplo, la Caja de Seguro Social, que es el Sistema Asistencial de Salud de Costa Rica. En la política de salud tenemos guías competentes de rectoría para la garantía del derecho a la salud de la población migrante, tenemos una política de integración de migración y un plan nacional de integración que se aplica en nuestro país. Recientemente sufrimos una crisis migratoria de gran envergadura sobre estos migrantes que buscan a los Estados Unidos como norte, y muy concretamente los que provenían de Cuba, gracias al efecto llamada que la ley pies secos, pies mojados ha ejercido sobre la población cubana, invitándolos a llegar a los Estados Unidos para obtener la regularización. Ante un rumor de que las relaciones entre Cuba y Estados Unidos empezaban a normalizar y el peligro de que dicha ley desapareciera, recibimos una avalancha de migración que venía esencialmente desde el Ecuador, cruzando por Colombia o directamente por el mar a Panamá y de ahí a Costa Rica y en adelante. Nosotros llegamos a documentar en el año entre el 2015 y el 2016 23.500 personas que pasaron. Y entre el 2014 y el 2015, por ejemplo, Estados Unidos recibió 43.159 personas. Nosotros efectuamos un operativo de interrupción de las organizaciones criminales que traen estas migraciones, y se generó un estancamiento de gran cantidad de personas en territorio costarricense. Tuvimos que actuar humanitariamente creando 44 albergues en todo el territorio nacional, albergues que fueron construidos oficialmente por el Estado, pero con la participación activa de la comunidad y la anuencia de los gobiernos locales. Por lo tanto, podemos hablar de algún margen de solidaridad de la población costarricense a la hora de atender estas poblaciones que recibieron no solamente alimentación, sino servicios básicos generales, incluidos la atención sanitaria completa. Actualmente hay que decir que la mayoría de los cubanos que llegaron ya han salido del país. Se desarrolló una operación, hubo que construir un puente aéreo que conectó vuelos Costa Rica, El Salvador, Costa Rica, México, y pudimos sacar por esa vía a 7.822 personas. Concretamente por vuelos 4.346. Sin embargo, hay que decir que al menos unas 3.476 salieron por sus propios medios al no querer esperar el trámite burocrático de tener que esperar su vuelo. Esto fue necesario hacerlo ya que el gobierno de Nicaragua no quiso participar en una propuesta que efectuó Costa Rica de que se efectuara el puente terrestre garantizando el traslado vía tierra de los migrantes hacia territorio estadounidense. Actualmente contamos con una nueva crisis, es el tránsito de personas que provienen de África y de Asia vía barco desde el sur de Europa o directamente de África a Brasil, cruzando toda la tierra suramericana, y actualmente en Costa Rica hemos documentado personas de distintos orígenes. Haití, Irán, Bangladesh, principalmente Nepal también está participando en este problema, con las subsecuentes problemas de salud y a los que tenemos que contribuir a ayudar por la situación con la que vienen viajando. Hemos documentado, por ejemplo, en nuestro país, ellos tienen derecho a la asistencia sanitaria. Sin embargo, ese trámite no siempre es tan expedito, porque se debe reconocer la existencia de los migrantes en territorio nacional, y como sabemos, este reconocimiento no siempre es tan expedito. La Cruz Roja nos ha ayudado muchísimo, queremos reconocer la participación de la Cruz Roja desarrollando estos albergues, y hay que decir que hemos llegado a documentar en su mayoría problemas de salud por infecciones. Tuvimos un caso de un nepalí que falleció en un hospital por un sangrado digestivo alto, probablemente producido por una úlcera. Como bien lo decía la doctora Chang, el estrés al que vienen siendo sometidas estas personas es descomunal, y el estrés se complica por las limitaciones nutricionales del viaje como tal. Finalmente, hay otro caso que está siendo atendido en nuestro país, que es el de un paciente de origen africano, sin llegar a determinar de dónde, que presentó síntomas de un probable glioma en cavidad craneana. La mayoría de los problemas son de salud causados por infecciones, y hay que decir que actualmente contamos con más de 1.500 personas distribuidas en 3 albergues que hemos constituido para abordar este nuevo problema, pero la cifra de crecimiento es exponencial, y actualmente nos encontramos con la situación de que en el caso de los cubanos sí iban a ser recibidos en los Estados Unidos. En el caso de este resto de migraciones de todo el mundo, no tienen una salida ni un futuro legal aparentemente cerca. Así que pues estamos coordinando con los distintos organismos internacionales como el ACNUR, como la Organización Internacional de Migraciones, la Organización Mundial de la Salud y la Oficina Regional para las Américas de la Organización Panamericana de la Salud para abordar la situación de forma integral como debemos y de forma regional. Muchas gracias.
Muchísimas gracias, Ministro. Thank you very much for that intervention and for giving us a picture on both sides of both the transits and the destination questions faced by Costa Rica. Our next panelist is from Liberia. It is amazing that we've actually been able to have her here for this entire time. I think she's booked on virtually every other side event panel during her time here, partially because of Bernice Don, who's the current Minister of Health in Liberia, worked very, very closely with WHO, with our own team, at the height of the Ebola outbreak in Liberia, and she played a key role in combating the virus, where she served first as Chief Medical Officer and now as Minister. I'd like to turn the floor to her for hearing about Liberia's experience vis-a-vis this issue on migration and health. Bernice.
Thank you, and good afternoon to all. Liberia is delighted to be a part of the panel. Suboptimal capacity of the national health system, including the international health regulation core capacities required for surveillance, detection, and response to outbreak and other threats, contributed to the scale of the outbreak of EVD in 2014-2015. The spread of EVD within the most affected countries was further aggravated by highly mobile populations. Prior to 2014-2015 EVD outbreak, Liberia had over 22,000 registered refugees from neighboring countries in 5 counties in the country. We first saw our first confirmed case in March 2014 as a result of a cross-border movement of an infected person from the first outbreak epicenter in Guinea. Significant cross-border activities exist especially population movement between Liberia, Sierra Leone, and Guinea, due to cultural, family, and economic reasons, and sometimes to even seek medical attention. For the first wave, a rapid response by the government, with support from WHO, CDC, US CDC, and MSF Belgium, were able to confine the outbreak geographically and in number. So we were able to limit the cases to 6 confirmed cases, and then in 1 county, which is Lofa. Lofa shares international border with Guinea and Sierra Leone. We had a second wave by late May, and this wave spread from Lofa County as a result of mobility of the affected population from rural to urban area. So in June 2014, the first case of EVD confirmed in an urban, densely populated slum in Monrovia, the capital city of Liberia. At that time, there were insufficient capacities for isolation of infected individuals, poorly equipped and trained health workers that were unable to effectively implement infection prevention and control measures at health facilities, and the initial lack of community awareness and prevention and control measures for themselves. So that dramatically caused an exponential rise in the EVD spread. By August 2014, Liberia was reporting about 60 to 70 suspected cases daily. Several individuals from Monrovia fled the city and went back to their rural homes, once they started showing signs and symptoms of the disease. And that resulted into spread of the infection to every county, all 15 counties in the country. So by October, November, all counties had cases. We also at that time saw migration from the country to Nigeria and to the United States. The government-led EVD response effort was generously supported by technical, financial, and logistic support from international community, integrated specific strategies to address spread of the EVD transmission by mobile populations. So we intensified social mobilization and community engagement to ensure that communities and their leaders were aware of the risks and dangers of transporting sick persons and dead bodies from infected areas to non-infected areas. We also did extensive capacity building of thousands of health workers and frontline volunteers in surveillance and contact tracing, infection prevention and control, case management, as well as community engagement and social mobilization. At the height of the outbreak, that was around August 2014 to February 2015, the head of state imposed a national state of emergency. And that was associated with curfew, banning of movement of dead bodies across county borders and closing international borders. When the national state of emergency was lifted and international borders were opened in February 2015, a multi-sectoral border coordination group led by the Ministry of Health, with participation of the Bureau of Immigration, Liberia National Police, as well as the IOM, US CDC, other partners, was constituted. And their main role was to coordinate border activities. They strengthened cross-border surveillance, screening, infection prevention and control, as well as community engagement. And at that time, UNHCR also continued the partnership with the Ministry of Health and provided services for the refugee. The key preparedness and response components were also integrated into those services. The intensified EVD response efforts in Liberia had a desired effect. So by the end of 2014, the incidence and geographic spread decreased significantly, and by May 9, WHO declared the first end of the human-to-human transmission of EVD in the country. Since then, Liberia had 3 flare-ups, July 2015, November 2015, and January 2016. The flare-ups have been kept very low, 3 to 6 cases each in 1 or 2 counties. And that is a result of significant increased capacity in surveillance, detection, and response at both national and subnational levels. There were 3 key lessons learned as I conclude. First, the government leadership and ownership of the overall response effort that enhanced coordination of all response actors, including international responders, national responders, civil society, and community leaders. 2, strong and effective partnership and multi-sectoral collaboration. The strong technical, financial, and logistic support of the international community ensured that identified local strategies and tactics could very rapidly be operationalized. The third is effective community engagement and leadership. Community leaders and members implemented effective and innovative strategies to ensure effective community-based contact tracing activities, as well as infection prevention and control measures, including limiting movement of symptomatic patients, ensuring safe and dignified burials of patients. So with this, I will encourage WHO to support the EVD most affected countries as other resource-limited countries to mobilize the required technical, financial, and logistical resources to consolidate and implement lessons learned from the EVD outbreak as part of the national efforts to build more resilient healthcare delivery system, including compliance with all the IHR core capacities. Thank you.
Thank you very much, Minister Don, for that intervention and the successful work and collaboration with a lot of the organizations that are here today. If I can now, I'll just turn to Sri Lanka. I will just note, as someone who has stood through many technical briefings, there seems to be some cachet if you keep a lot of people in the back of the room standing the entire time. I'm not that way. I don't know if Ambassador Swings agrees with me. Being an American, I have no protocol, so please come down here. There's a few seats over here and over there. But without further ado, I'd like to very much welcome our colleague from Sri Lanka, Dr. Palitha Mahipala. He's the Director General of Health Services at the Ministry of Health in Sri Lanka, and a post he's held there since 2012. And we are very pleased to be working with Sri Lanka on this issue of migration and health. Looking forward to meeting later there this year. You'll hear more about that as the days develop. But I'd like to turn to you, Dr. Mahipala, for your intervention. The floor is yours. Thank you.
Thank you, Mr. Chairman. Excellencies, distinguished presenters from member countries, ladies and gentlemen, Sri Lanka wishes to share the experience in multi-sector engagement, both at national level in the policy process and international level for implementation of the national migration health policy. The Sri Lanka National Migration Health Policy was developed and launched in year 2013 to address the multifaceted challenges in health due to migration. They are due to outbound, inbound, and internal migration, and health and social issues of families left behind of labor migrants. Our policy addresses all these issues pertaining to us in the migration cycle. Ladies and gentlemen, this looks very complicated and complex as much as health and migration. The policy development, we followed an evidence-based approach, which was supported by International Organization for Migration. At the beginning, a rapid situation analysis was conducted using this framework developed by us, and we identified gaps where further research studies were commissioned. Now, I don't want to go into details. We have focused on 4 major areas. As time is limited, I don't want to go into detail about the research studies which we have done. Mr. Chairman, the policy process we initiated was an interministerial and interagency one. We included all relevant stakeholders. The Ministry of Health led the process through a National Steering Committee on Migration Health, where high-level decisions were taken. The National Migration Health Task Force comprised of technical focal points representing all relevant ministries, UN agencies, and academia. A Migration Health Secretariat was set up in the Ministry of Health Planning Unit to coordinate all these activities. Ladies and gentlemen, we understand the importance of sharing our intentions as well as the progress made. We table our progress made on the 2008 resolution on health of migrants at World Health Assembly in 2011 and 2013 in the form of report cards. Although it was not required at that time, we were the only country that reported progress, and we think that showcasing accountability is very much important. We had 30 years war, which was ended in 2009. We faced certain health challenges from Sri Lankans who were returning to the country after a long period of living South India. We took a non-discriminatory approach. And they were made aware of comprehensive health services that were available to them upon return. We did not check them at the entry points. They were linked to the community health services as soon as possible after reaching their destinations. Now, Sri Lanka, as you know, has reached elimination status for malaria control, with 0 indigenous cases since 2012, 3 years past now. Awareness is made at point of entry to motivate voluntary screening for those visiting Sri Lanka from endemic countries. And we have also adopted a follow-up system that is very important for us to sustain the achievement we have had. And the National Migration Health Policy does not pose any discrimination to those wanting to migrate based on gender or their age of children. We are together with the Ministry of Foreign Employment and other relevant ministries developing a tool for a coordinated care plan, which will look into the health and social issues of families, including the carers of those who left behind. And ladies and gentlemen, Sri Lanka is part of a multi-country study being conducted in collaboration with IOM to assess the quality of outbound health assessment provided by different health assessment providers. Our policy recognizes the need for national guidelines to streamline health assessments. The key aim is to link those with identified health problems with the health services to make them fit for any future employment. And the Colombo process. The Colombo process is a forum that originated in 2003, where 10 Asian countries discussed issues of temporary contractual workers. And in the past, mainly it was focused on labor, welfare, and wages. But today, we were able to get health and migration into the agenda. That was a very important step taken forward. And also, ladies and gentlemen, the senior officials meeting, which was held in Colombo 2015, it was noteworthy to state that there was a para included in the concluding statement about health and migration. And also, there are international dialogue taking place in Geneva among permanent representatives to UN. With other several countries, the Sri Lankan ambassador is taking the leadership in this. I consider this is another forum where we can discuss about the migration and health. And finally, Mr. Chairman, ladies and gentlemen, Sri Lanka recognizes the importance of regional and global dialogue on migration and health. His Excellency, the President of Sri Lanka, Maithripala Sirisena, made an invitation for the second global consultation on migrant health to be conducted in Sri Lanka this year. The first was held in Madrid, Spain, 2010. We think it is timely for such a global consultation to reach consensus on issues of health access to migrants and improving the health system to respond to challenges of health due to migration. Many other regional and global platforms exist to enhance the dialogue on migrant health. We believe that these platforms should be explored to discuss how we can take forward the agenda for migrant health. With this announcement of the second global consultation on migrant health, I would like to conclude my brief presentation. I thank you.
Thank you very much, Dr. Maithripala, for that. And for those interested, please see our representative from Sri Lanka for their technical brief on migration. Health is something you can get available from him at another time. But I'd like to turn to our last panelist in this group before we do a bit of musical chairs from Thailand. WHO has a long relationship and a close relationship with Thailand, especially on this issue and especially on their experience in expanding universal health coverage to migrants. Dr. Pusit Prangkongsai was appointed Director of International Health Policy Program at the Ministry of Health, Public Health of Thailand from October 2010 to December 2014. He's currently the Director of the Bureau of International Health for the Ministry of Public Health, and I would like to pass him the floor for his intervention. Thank you, sir.
Thank you, Chair, and good afternoon to all. Thailand is an upper middle income country which sustains the economic growth and relative social stability compared to neighboring countries in Southeast Asia region. With higher minimum daily wage, better job opportunities, and better quality of public service and infrastructure, Thailand attracts millions of permanent and temporary migrants workers, both documented and undocumented migrants from neighboring countries, namely Myanmar, Cambodia, Vietnam, and Laos PDR. In 2015, there are approximately 4.2 million of non-Thai citizens living in Thailand. This is equal to 6% of total Thai population. The IOM estimates that there are almost 2 million of undocumented migrants and their dependents residing in the country. From economic perspective, the ILO estimates the contribution of migrants to Thai economy around $2 billion per year, which were around 6.2% of country GDP in 2007. the demographic change of the country to become an aging society and high demand of labor-intensive industry are the key driver of the demand for migrant labor in Thailand. There are 2 health insurance schemes for migrants in Thailand, Chair. First, the 6th Social Security Scheme for migrant workers in the formal sector. Imported migrants under the MOU between Thailand and neighboring countries, and also migrants who have complete national verification process. This Social Security Scheme is under the responsibility of Social Security Office, Ministry of Labor. Second, compulsory migrant health insurance scheme or CMHI for undocumented migrants and their dependents who are working in the informal sector. This scheme is responsible by Ministry of Public Health of Thailand. The CMHI managed by Ministry of Public Health of Thailand start registering undocumented migrants in many big cities and provinces. Currently, the premium of CMHI is only 1,600 Thai baht or $44 per capita per year. And CMHI also provides health insurance coverage for migrants, dependents, and children aged under 7 years with a modest insurance premium at 365 Thai baht or around $10 per capita per year. The benefit package of CMHI is similar to that of Universal Health Coverage Scheme for the Thai population. It covers curative care, OP services, hospitalization, health promotion, and disease prevention. Also, antiretroviral for people living with HIV/AIDS, and a wide range of essential health services. Ladies and gentlemen, despite a significant achievement in migrant health policies, we still have a number of key challenges to be addressed. First, there is a lack of policy coherence among different ministries. For example, Ministry of Defense, Ministry of Interior, Ministry of Labor, and Ministry of Public Health Thailand. The government should have a clear policy on migrants and non-Thai citizens who are residing in the country. Second, many of Thais and public health workers still have negative perspectives on migrants. Migrants and their dependents are still seen as additional burden and workload for healthcare system, and also carriers of serious communicable disease. Third, unavailability of data. Since data on migrant health is very important for monitoring progress of the migrants policy and assess the current situation, data on migrants in Thailand are still fragmented, not timely, and inaccurate. Many national representatives' household surveys in Thailand deny to collect household data from undocumented migrants. So our recommendation priority is to advocate for having the paradigm shift on migrants. Migrants should be seen as part of the social development of both recipient and original countries. Also, should be counted as a human resource and social asset of the countries as well. Lastly, we would like to request the WHO and other development partners to document experience and document good practice from countries having a migrants' health policy, and then share such evidence to donors and policy makers and developing countries. So thank you for your attention, Chair.
Thank you very much for that, and especially for that call for the sharing of good practice. No doubt there will be some that will come from Thailand itself, and this session can actually feed into that. This is that session, for any of you who are football fans, where the sort of young replacements come in and they jump up and down and they come in and invigorate the team. So we're going to ask our second team to come and join us on the panel with a very big thanks to our panel here today. Thank you all very much. I'll take the opportunity to take a couple of comments from the assembled group here. I have a couple of colleagues that have very important messages we want to get out, but I did also want to acknowledge some of our invited guests that are here. And if I could turn to our colleagues from MSF.
Thank you, Mr. Chairman. Your Excellencies, distinguished delegates, UN representatives, and civil society. We're facing the greatest displacement of humanity in decades, with more than 60 million people forced from their homes by war, misery, or oppression. For Médecins Sans Frontières, we witness daily the humanitarian consequences of mass displacement, from Southeast Asia to camps in South Sudan and Lebanon, along transit routes in Central America to the shores of Europe. In all these places, displaced people are given no or inadequate access to healthcare most of the time and continue to suffer from inhuman migration policies that provoke preventable medical emergencies themselves or continue to deteriorate their health on a regular basis. As doctors, we have a responsibility to safeguard the health of these vulnerable people. Free and universal access to health care for displaced people in camps, in transit, or in host countries will not only save their lives and preserve their dignity, but protects the health of all of us. Today, the right to seek asylum is under attack. The responsibility to humanely welcome people seeking refuge has degenerated in recent years from being perceived as a burden to now feared as a threat to national security. Borders are closing. Human beings are held in squalid camps of detention centers in Europe, Africa, Asia, and the Americas. The largest refugee camp in the world, Dadaab, is now in danger of total closure, portrayed as a security risk to Kenya. Refugees have become scapegoats, forced to suffer the consequences of the political failure of states to share the responsibility. The medical consequences of this policy-made crisis cannot be underestimated. Our doctors treat people in transit for respiratory tract infections, trauma, psychological distress that are almost always the result of the horrific migration journey itself or the appalling reception conditions on arrival. 93% of our almost 80,000 patients along the Western Balk route last year present these experiences and symptoms and find no response to their plight. In countries hosting refugees, access to primary health care is frequently difficult or unavailable for everyone in need. Undocumented people do not dare go into our hospitals for fear of being arrested. Doctors in many countries are being asked to betray their patients and report them to the police. This serves only to push people underground who have already fled extreme hardship. And we need to realize invisibility means vulnerability. This results in severe delays and treatment reception. This seems to be the cause of little concern so far. We see Europe advancing its most organized attempt yet to push people back instead of taking them in. Refugees in Greece, suspended in an uncertain holding pattern, waiting either to be forced into isolated and poorly equipped camps or to send back to Turkey under the recently signed EU-Turkey deal. This agreement incentivizes border closures and pushes responsibilities back to countries neighboring Syria, who are already struggling to offer protection to millions for many years, as it was rightfully mentioned early before. Closing borders and outsourcing migration management to other countries do not stop desperate people from moving. It simply shifts their route to often more dangerous ones, jeopardizing basic needs and rights while fueling human trafficking and smuggling business. The medical challenges for caring for people in transit are huge, but they are not unsurmountable. Lessons learned by MSF over the past 5 years show that this is possible, giving patients the ownership for the medical records while they are on transit, providing enough medication so that the drugs last for their journey has already improved the health of thousands suffering chronic conditions. Employing trained cultural mediators build trust and encourage patients to seek care. In essence, it's about stop discriminating them. It's about stop subjecting their right to health to administrative conditions in every single country. If the global displacement crisis were a communicable disease, it would have been declared a public health emergency of international concern by now. Caring for the displaced is not simply our medical obligation, but it's a responsibility of the state. Displaced people should have a free and unhindered access to health care, regardless of their legal status. And the state needs to switch their mindset from how to deter people from coming to how to best care for them instead. This is how we, And you, as health authorities, can ensure that no one is left behind. Thank you very much.
Thank you very much. Now, with I'll take one more comment from the floor. Typically, these are always billed as question and answers, sort of questions from the floor. They're very rarely questions. It's a very powerful statement. But anyway, if I can turn to my colleague from the U.S. government from USAID for a comment on a question, comment, very briefly, please.
Your Excellencies and distinguished guests, thank you for this technical briefing and for the invitation. I'm Amy Kay, and I'm the Health Advisor with USAID's Middle East Bureau. As Dr. Chan and Ambassador Swing and others noted, Syria is one of the most critical and complex crises of our time and gives us the opportunity, or rather the necessity, to change the way we work. This includes, as Stephen Corliss mentioned, investment in local solutions and local communities and local systems because the majority of refugees reside in host communities. I'll focus my 2-minute comment, my very brief comment, on our work in Jordan, where I was based just prior to coming here. We considered Jordan's health sector a success in 2012, and USAID helped build a robust health system over the past 5 decades. We had remarkable improvements. For example, nearly all of Jordanian mothers, 99%, labored and delivered with a skilled health provider. And more than 80% of births, whether to Jordanians or refugees, were in USAID-supported hospitals. However, the influx of refugees, and this is 1.3 million in Jordan, spiking their population 25%, and I know our colleagues in Lebanon are experiencing similar strains. This has overwhelmed and weakened the system, and demand now far outpaces capacity, and progress on maternal and child health is threatened. Previously eradicated diseases are now reemerging, and Jordan's government has noted that since 2013, the cost of providing free and subsidized health care to Syrians has ballooned to $2 billion. USAID's health office in Jordan is working with our Jordanian partners, including the Ministry of Health, to meet increased demands in the community in which they're facing these demands. So this includes quality health services to increase the resiliency and stability of the system to respond to current and future stressors. And I'll give you a few examples. In Irbid, in northern Jordan, we are expanding the Princess Rahma Pediatric Hospital to increase occupancy by 30%. In Amman, we plan to expand the emergency department of the main referral hospital, Al Bashir, so it can adequately serve 50,000 patients each month. And we are working across Jordan to improve quality of and access to primary health care for 75% of the population, with an emphasis on urban areas where the majority of refugees are concentrated. And this includes universal health care. And we certainly have been working with our partners, including UNHCR, WHO, and other UN agencies and local implementers to make this a reality. The Middle East presents a new world in which we live, and we understand we need to deliver life-saving humanitarian aid and longer-term development and assistance at the same time. We're learning lessons of previous crises and coming up with better and earlier ways to assess the trajectory of crisis and its aftermath, and then tailor our approach to consider both humanitarian and development needs as the lines are blurred. And the goal is to better address fragility of communities, to not only respond better to frequent and protracted crises, but to build resilience and local capacities to prevent or mitigate disasters. So finally, thank you again for the opportunity for this briefing and the opportunity WHO provides to work together and coordinate. We look forward to working with EMRO and WHO regionally and country and globally to strengthen the health response as the crisis in the Middle East region continues to grow in complexity and in need. Thank you.
Thank you very much, Amy, for that intervention. And with thanks to our team who's come up here, no doubt they finished their stretching and are now able to begin talking. But if I could, this next panel, which has already been a bit previewed by our 2 interventions, really focuses on Leave No One Behind. Globally, 60 million people are currently forcibly displaced, and these large influxes affect both migrants and refugees as well as the host population. And we'll look at countries addressing the health needs of refugees, internally internally displaced persons, asylum seekers, as well as affected host populations. Many countries have developed and are implementing national migrant health policies and are providing universal health coverage for those populations. And we're very interested to hear their lessons for us from Greece, Italy, Lebanon, and Turkey. And without further ado, I'd like to ask Dr. Ioannis Basakos, who is the Secretary General for Public Health at the Ministry of Health in Greece. He's coordinator of the Committee of Health Coverage of Refugees, Migrants, and Vulnerable Groups, and head of the Committee for the National Action Plan on Migration and Health. The floor is yours. Thank you so much.
Okay. Thanks, Ambassador Swing, for the excellent cooperation. Around 900,000 people arrived in Greece by sea during 2015, and a further 150 during the first months of 2016. Demographics imply that, with amongst them being 38% of children, migration flows are even more vulnerable in terms of health. At the moment, the number of migrants and refugees is exceeding the capacity of designated sites and settlements, but as we speak, the situation is being closely monitored. Efforts concentrate at improving the capacity, and the issue will shortly be resolved. According to robust UNHCR data, food, health access, and WASH are covered in an acceptable manner, but are still subject to certain improvements. The main healthcare needs are mostly due to 5 conditions: trauma, respiratory tract infections, chronic diseases, and gastrointestinal and skin maladies. Constant healthcare provision and emergency treatment are needed in conjunction with efforts to deter the spread of infectious diseases, adhere to the principles of public health, and improve living conditions in the migrant and refugee sites, to address healthcare issues, and to respect, protect, and fulfill human rights. The aforementioned illustrate the core values and elements of the Greek National Plan for the Health of Moving Populations. Public health measures were determined by accounting all relevant factors, including optimal camp and setting location, easy access to food, water, and electricity, preservation of sanitation and hygiene, ensuring communication and warnings, epidemiological monitoring, and vaccination of children. Specifically, epidemiological monitoring includes reinforcement of the already existing system for compulsory reporting of specific diseases and a sentinel system for epidemiological monitoring of symptoms and syndromes. Overall, we proceeded to an evidence-based prioritization, both in short and long term. Moreover, a framework was created with view to allow the involvement of national and international organizations in an effective manner. The understaffing and underfunding of the national health system due to the austerity policies imposed by the memorandum made our task of treating refugees and immigrants even more difficult. In a stifling environment and with the national health system in tatters, the proud endeavors of health workforce, along with the touching assistance of the Greek citizens, volunteers, solidarity organizations, and NGOs, contributed to smooth progress on the matter. The magnitude of needs implies that ensuring financial support and expertise are pressing matters, which could constitute a priority area for WHO. The projections for a permanent residency of at least a part of refugee and migrant population in Greece and the change of seasons bring forth a necessity to focus on chronic disease management, children vaccinations, maternal care, food inspections, and mosquito control methods, among others. In an ever-changing environment, versatility and alertness, combined with strong political will and commitment, can unilaterally shift the point of view for migration flows from trouble to a tremendous opportunity to strengthen public health policies in each country, which encompasses the basic lesson learned from the Greek experience. Furthermore, Our experience could be epitomized by the following. Priority to public health policies against, let's say so, security measures. Our experience says that the best security and safety measure is protecting public health. Campaigns of universal immunization are necessary, assessing need in accordance with seasonal variations, coordination and optimal utilization of NGO capacities, consideration to delicate issues that affect public opinion. The refugee and migrant protection in terms of health is the fundamental measure to protect public health. Management of vaccine supply in a way that does not affect the national reserve, handling of the workload of healthcare professionals, cultural health mediators and psychosocial support, maternal, children and mother-child care. At the end, solidarity, cooperation and respect of human rights is the key. So the example of how Europe has to be supported and expanded, because refugees and immigrants issues are not a Greek nor a European, but a global challenge. Thank you very much.
Thank you very much, General Secretary, and for also respecting the time so well with those thoughts on the National Action Plan. If I can turn to our Italian colleagues, Dr. Ranieri Guerra. He's the Director General for Prevention at the Ministry of Health in Italy. Be speaking today on behalf of Minister Beatrice Lorenzin. There's the Italian Minister for Health who was unable to be in Geneva today, but Dr. Guerra and Italy have been a great champion of this issue, working also with Euro, as you heard RD explain, but also we hope working more with headquarters on this very important issue. So Dr. Guerra, the floor is yours.
Much. Ambassador Swing, Regional Director Authorities, colleagues, friends, thank you very much for being here today and listening to us. As you said, Minister Lorenzin was prevented to come here from last-minute political engagement, and of course she was unable to show directly her personal commitment and concern. A few fast words. If you no slides, no movies, nothing at all, but you can access YouTube if you want. You digit Italy and migrants, you will see the most spectacular rescues images at sea. As a matter of fact, in the last 2 days, our Navy rescued more than 9,000 migrants who were otherwise going to die in front of the Libyan coasts in 33 different operations. As for today only, we have 11 ships at sea now, carrying 4,000 people. We are proud of what our people are doing. Let me remind you that while the world mobilized to face the Ebola crisis, and WHO is now reforming its governance to reestablish its capacity and leadership in emergency management, thousands of lives are lost in the sea now, more than the estimated deaths from Ebola. While migrants coming from the Middle East and moving to Central European countries are predominantly families and small communities, people crossing the sea are mainly individuals, coming from a variety of countries, sometimes infiltrated by criminal organizations. The male proportion is decreasing in favor of females and unaccompanied children and teens, whose needs are even more challenging. We're also proud to participate in this session, which brings together so many countries and so many interests, listening to our voices, as we cannot act alone and will not be able to continue our mission without global support. We spent 2 years alone trying to stimulate the world's attention. Today, no one denies the challenge, and all countries and agencies may finally decide to join forces. The alternative for the European Union is disintegration, as seen by threats posed on the Schengen Treaty. We are particularly grateful to WHO Euro and Dr. Jakob personally for her constant and qualified support and for the successful advocacy that led to the Rome Conference in November 2015. The outputs of that conference are a policy and a strategy draft and a plan of action endorsed by the SCLC Euro last week. In order to improve first aid and rescue at sea, we are working closely also with the International Organization for Migration on Project PASSIM, aiming at identifying situations of vulnerability and need of care very rapidly before arrival. Together, we're also developing a comprehensive information system funded by the European Union. The documents generated by the constant collaboration between Italy and WHO aim at providing the required evidence and an impartial view based on technical and scientific knowledge, objectivity, and the possibility to advocate for migrants' needs and expectations, overcoming the reluctance of a consistent number of states to accept the simple fact that migration is one of the leading forces shaping our century, and that it will not disappear and cannot be ignored. As Dr. Jacobs said, the excellent collaboration with WHO will materialize in a resolution for the next September Regional Committee, and possibly in the updating of the resolution WHA 6117/2008, as we have pointed out during the general discussion this week. As you know, our position is based on an explicit human rights approach, no matter whether we deal with refugees, asylum seekers, migrants, be they documented or not. We want to go beyond the constraints of an outdated and unnecessary classification and consider them all victims and not perpetrators, deserving to be treated with compassion and humanity. Italy is a land of migrants, with 15 million Italian passport holders around the world, and with 65 million second and third generation ethnic Italians, pairing the number of current residents. They all look at us and support our approach, reflecting their past struggle for survival. We acknowledge the different causes and triggers of migration, from criminal human trafficking, 90% worth $5.5 billion cashed yearly, to climate changes, from violence and war to droughts, poverty, and the legitimate aspiration to improve life conditions. And we have no doubt that migrants must be provided with quality health services, as Italy does, from onboard screening and first aid to sophisticated hospital care on arrival to mainland. We have adopted the DG's mantra that no one ever must be left behind, and we are practicing that accordingly. We are going now further on with the Migrants' Compact that the government of Italy has presented to the European Union and to the African leaders who met in Rome 10 days ago. It is by means of consultation, coherence, solidarity, and a common approach that we will succeed, as we do not want to see more dead children on a beach or floating in the sea. We hope that our colleagues from WHO and from IOM, whose Rome office has been an extraordinary partner on several aspects of migration, will continue working together with Greece, Malta, Cyprus, Turkey, Jordan, Lebanon, and other EU member states, as well as with EMRO and AFRO. We need all goodwill parties to advocate strongly and continue implementing concrete actions, as Italy is doing. In fact, our universalistic health system provides care not only to all ethnic Italians, but also to the hundred thousands who have landed and continue to land, in a spirit of equality and equity, following the WHO Venice office's guidelines. They believe in us and trust we can meet their hopes for a better and healthy future. On our side, we will continue advocating for their right to access unrestricted care and cure. The quoted joint WHO-Euro-Italy program FAME and other collaborative work with IOM and HCR aim at assessing countries' capacities to do so, and facilitate the adoption of contingency plans allowing for the delivery of a full package of services. I want to extend Minister Lorenzini's deep appreciation to Dr. Jacobs' vision and more than friendly collaboration, and to the DG's global perspective that have led us here today. May I conclude now with an appeal in favor of the symbol islands of Lampedusa and Lesbos competing for the Nobel Prize for Peace. 5 million Sicilians are constantly sharing their homes and their resources, and Sicily is not the richest area in Italy, nor it is in Europe, in silence and respect, being an example to us and to the world. Recognizing this, our Prime Minister announced that the 27th Italian G7 meeting will take place in Taormina, Sicily. 10% of Italian residents are already first or second generation migrants, and they enjoy full rights and full access to all services. May I finally acknowledge the bravery and dedication of the Ministry of Health Border Health Office's staff, supporting the Regional Health Authority of Sicily, the Navy, and the Coast Guard in their exceptional capacity to rescue lives. Thank you very much for your kind attention and for what you will do with us next.
Thank you very much, Dr. Guerra, for that. And with Ambassador Swing's permission, it's quite clear that we are not finishing at 2:15 as we had originally planned. But I would encourage you, it'll be very difficult for them to start without everybody here in the room. So we'll just keep going. Normally we would restart the proceedings at 2:30, and we'll go till 2:29 and about 45 seconds. Recognize that a few of you have official duties, but please stay and hear the rest of the interventions, and we have a couple of interventions from the floor I want to make sure to get to. So with that, I'd like to turn to our colleague from Lebanon, Professor Walid Ammar, who's Director General, Ministry of Public Health in Lebanon. He's been the Director General since 1993, was appointed in 2011 as Commissioner in the United Nations Commission on Information and Accountability for Women and Children's Health, and has served as a member of the EB at WHO, until 2012 to 2015, and currently member of the WHO Emergencies Oversight and Advisory Committee. So, Professor Ammar, the floor is yours.
Thank you. Thank you for giving me the opportunity to explain the difficult situation in Lebanon. Dear colleagues, ladies and gentlemen, refugees registered in Lebanon represent 25% of its population. This is the highest refugee concentration per inhabitant in the world, and is exerting tremendous pressure on the country's infrastructure and institutions. Displaced Syrians are spread all over the country with high concentration in the poorest area. 85% live in 180 localities, in which 67% of the host population lives below the poverty line. 41% of the households among the displaced have at least one pregnant or lactating woman, while 33% count at least one member with a specific need. Chronic diseases are prevalent, particularly diabetes, renal failure, cardiovascular disease, cancer, and mental disorders. The disruption of immunization activities in Syria, coupled with poor living conditions, has heightened risks of the disease outbreaks, including measles, mumps, and polio, and the introduction of new diseases such as leishmaniasis. Rising incidence of tuberculosis, including multi-resistant TB, and waterborne diseases such as hepatitis A, have been noted since the advent of the crisis. The outbreak of poliomyelitis in Syria and Iraq in 2013 was particularly alarming. It was faced by a nationwide door-to-door vaccination campaign that led to a high level of immunization coverage among Lebanese and children Syrian and alike, and maintained Lebanon polio-free. While the Ministry of Health, with the support of the UN agencies, is meeting to a certain extent the refugees' needs for primary health care, access to hospital care remains limited. Secondary and tertiary care for displaced Syrians are financed by UNHCR at up to 75% of the total cost and are restricted to life-saving emergencies, delivery, and neonatal care. The 25% co-payment remains most often unpaid and causes increasing budget deficits, especially for public hospitals that are struggling to remain operational. Whereas patients that do not fit the UNHCR coverage criteria, mostly those with chronic illnesses, are suffering from the disease and its complications and find their conditions worsening. UNHCR has repeatedly stated in its reports that even for prioritized life-saving interventions, financial resources are severely stretched. Despite the Syrian crisis, however, the Lebanese health system is still showing considerable resilience. Health facilities at the primary, secondary, and tertiary levels remain functional and are known for providing good quality of health care. Lebanon has been able to take the necessary measures to face communicable diseases and pandemic threats, preventing major outbreaks. In terms of health outcomes, and despite the ongoing insecurity climate and socio-political instability for decades, the Lebanese healthcare system has been able to sustain achievements like the decrease in out-of-pocket expenditures while improving the health status of its population. Despite the strain caused by high fertility rates among the Syrian population, both maternal and child mortality rates, which include mortality among Syrians, remain relatively low. Lebanon is among the few developing countries that achieved both MDGs 4 and 5. However, the health sector is now threatened with underfunding and the resulting reduced capacity to meet the increased population demand and ensure the continuity of health service provision. Responding to the needs of displaced Syrians in Lebanon is a shared responsibility. Scarce resources ought to be directed strategically after careful deliberations with national authorities, instead of being solely driven by calls for funding emanating from UN agencies and NGOs. Therefore, a financing dialogue is urgently needed between donors and the Ministry of Health and partners operating in the health sector. The Ministry of Health encourages donors to reduce intermediaries and to finance as directly as possible national institutions providing health services. This would reduce administrative wastage and would enhance visibility, transparency, and accountability. The budget deficits borne by national health facilities as a result of the insufficient funding from the international community are too great for any institution to compensate for. Donors are therefore encouraged to address the inadequate financing with supporting the sustainability of health institutions in Lebanon. A health response strategy was developed by the Ministry of Health in line with the recommendations of a health steering committee, which includes UN agencies, the World Bank, the EU, and NGOs representatives. It serves two interdependent strategic objectives: to respond to the essential health needs of the displaced Syrians and host community, and to strengthen national institutions and capacity to enhance the resilience of the health system. In addition, of course, to preventing and controlling outbreaks and to preserving health security. We plead the international community to reorganize its aid and effort to serve this strategy. Thank you.
Thank you very much, Professor. Now to our last speaker, before we just take a couple of comments and close, and I give it back to Ambassador Swing to close. I'd like to turn to our colleagues from Turkey, Dr. Bahadir Sukakli, who will speak on behalf of Turkey and as Turkey's hosting of migrants and their experience in their holistic approach to help protect the rights and the health of migrants.
Thank you, Mr. Chair. Ladies and gentlemen, I'm very honored to be invited to this panel on behalf of my country, Turkey, and I feel privileged to address you on this issue. People move and live, think, make a living to earn. People migrate to flee death and oppression, to be able to think and live freely, or earn more, or learn more. An important element of the globalization and development is no doubt the ability of people to move rapidly and with greater ease. With this scope, we are discussing and preparing our roadmaps through 2030 for SDGs. We have to redesign our health systems resiliently to deal with the phenomenon covering the needs and expectations of these individuals, those becoming a part of our own communities. In a very timely manner, World Humanitarian Summit, which was held in Istanbul this week, provided the engagement of all partners of these goals and scope. it's obvious that together with this effective and huge start, all the partners once more faced with the depth of the problem and the need to cooperate and to unite globally and in long term to overcome all these. One other outcome is the unique presence of WHO in all these efforts. Turkey is and will be in full support of WHO for both decision-making procedures and also in the field. So Turkey is hosting more than 2.7 million Syrians in especially southeast of Turkey, and in all the country in different cities. How we try to behave to these people in concordance with the SDGs, we try to be behaving equal and inclusive without leaving anyone behind and taking care of every migrant individually equally. And we try to be people-centered, to take care of every individual's needs individually. And for all of this, we try to be effective and productive in cooperation of different sectors in Turkey and also internationally to serve for these efforts and try to support the humanitarian values with an understanding of hosting these people like our guests, but serving them like our own people. Of course, a holistic approach is needed for this, and firstly, when these people arrive to Turkey, we try to provide at the very basic nutrition and shelter for all these migrants. And later on comes the preventive health care services, the reproductive mother and child care services, and later on, when they settle up, curative services very inclusively, including tertiary health care services in Turkey. Let me give some basic figures about this. We have 26 temporary protection centers in Turkey, keeping now more than 260,000 people in camps. But this figure is less than 10% of all the migrants in Turkey. The others, more than 90%, is living in cities. So we try to make these people, whether in camps or in cities, basic healthcare services with 64 migrant healthcare centers in 17 provinces, and all these services are free of charge, and we try to be in equal quality with our own with services that we provide for our own population. Of course, there are difficulties on this. I will talk about these difficulties later on. And I have to add that all the medicines are free of charge for migrants, more than 2.7 million migrants who are recorded. Let me give some figures about the numbers of the services. Of course, these numbers may not reflect the complete picture because in the first 1 or 2 years of the migration especially from Syria to Turkey, the services were not that good recorded. So these are underestimates, let me say, but still huge numbers, and this provides the burden. There are some other figures that may reflect the health services in Turkey, but as a sum, we can say that if you provide these people with comprehensive health services, you can not only provide them good health, but solve their health needs that they brought from where they migrate, like cutaneous leishmaniasis in Syria. The total burden for Turkey is more than 10 billion US dollars, and only almost 5% of this burden is shared by the community, the global community, and these figures show how the burden might become for a country who receives migrants. There are different problems that we face: linguistic problems, cultural differences, well, overwhelmed healthcare staff, that's a great deal. And I talked about heavy financial burden, and the coordination problems always happens in any advanced country. In the way forward, we have to take care of SDGs. When you provide those SDGs for migrants also, you can solve the problems in their place, where they live. Aiming no poverty, good health, reduced inequalities, peace and justice. Thank you. I have to close my words shortly because we don't have that much time. Thank you, Chair.
Thank you. Well, I think we should owe a big thank you to both panels for being so timely. I just have a couple of, we really have no time for comments, but we're going to carve out time, even if a few of you may need to slip out. I have a couple of comments just from the floor very quickly with the RDs and ambassadors' permission. First to colleagues from UNICEF, and then to colleague Veronica Megarf, and then we'll wrap up. But first to our colleague from UNICEF for a quick, very quick intervention.
Thank you. Your Excellencies, distinguished delegates, ladies and gentlemen. UNICEF applauds the WHA for this technical briefing that is critically looking at this very important issue of migration and health. UNICEF considers this issue on at least two fronts. One being the need to abolish legal and practical barriers to accessing health care in line with the Convention on the Rights of the Child for all children, no matter their migration status or statelessness. And then on the need to support access to birth registration for all children. On the right to access health care, the CRC stipulates non-discrimination, and its committee has asserted that the enjoyment of rights stipulated in the CRC is not limited to children who are nationals of a state. These rights must be available to all children, including asylum seekers, refugees, and migrant children, irrespective of their nationality, immigration status, or statelessness. Most often, the practical barriers for migrant children occur under the guise of undocumented migrants, especially in many countries where service providers are obliged to report or denounce irregular migrants to migration authorities. This severely hinders access to health care for boys and girls with irregular migration status. Here in Geneva, as well as in many other cities, firewalls have been placed between service providers and immigration authorities, allowing migrants, including those with irregular status, to access those services without fear of reprisals. And then we have internal migrants where their children may also face barriers to accessing health care services, where their right to accessing it is bound to their place of habitual residence. Additional barriers for stateless children, the UNHCR estimates that about 10 million people worldwide are stateless, and many of these are children. The consequences for children in terms of access to health care can be serious. In more than 30 countries, children need nationality documentation to receive medical care. In at least 20 countries, stateless children cannot be legally vaccinated. A key action to preventing statelessness is through efforts to provide birth registration for all children, including those who are born to refugee, asylum-seeking, and migrant populations, as was already mentioned by Costa Rica. And UNICEF and UNHCR have both undertaken successful programs to ensure birth registration for refugee populations in camps and urban settings, and UNICEF works in over 80 countries to improve national capacities to reach full registration, in line with Goal 16.9 of the 2030 Agenda for Sustainable Development. Healthcare providers are a key entry point for birth registration. UNICEF, in cooperation with UNHCR and the World Bank, has already produced some excellent work on indicators for measuring migrants and their families' access to health care, as well as education and the right to work, and has piloted these indicators in Mexico and Tunisia through our engagement with the Global Knowledge Partnership on Migration and Development, NOMAD group. UNICEF is ready and willing to intensify efforts through closely working with partners to improve access to health services for all migrant populations, but also in child protection, education, and human rights, among others. Thank you.
Thank you so much. And again, just as our last intervention, I know a few of you had raised your hands and really wanted to say something. I'm really sorry we won't have the time for it. But again, I'll say something just at the end before handing back to Ambassador. But the child agenda very important, but also the gender agenda very important. Veronica, maybe to say a quick word.
Yes, my name is Veronica, Team Leader for Gender Equity and Rights at WHO. Global transformations are also gendered transformations, no more than in the context of global migration. Discrimination, barriers, resilience, and intersection between them must be used to understand movement among women. Perhaps the most powerful optic, the care chain, women as providers of care from moral, emotional to material, and yes, health care, will be explored by WHO this year. This time next year, WHO will launch the Director General's report examining women and movement, exploring these intersections. The report will identify key public health and human rights issues, challenges, and possibilities for intersectional action to improve health and well-being among women and girls. Obvious audiences are policymakers, programmers, social reformers, and everybody in this room committed to the 2030 agenda. Please pick up a flyer on your way out.
Thank you very much, Veronica. And now, with the RD's permission, I'd like to turn back to Ambassador Swing just for some concluding comments.
Wow, what a great group of panelists. I don't know about you, but I come away actually very inspired by what I've heard. I think the presentations have come from people who are on the ground, who know what's happening, who have the knowledge. They're not just giving us empty words. They've seen it, and I think we should all go away. I certainly go away both inspired and I learned a great deal. It's very useful. I want to thank all the panelists and thank the WHO and UNHCR for their working on this together. I think that it's clear. I wouldn't dare to try to summarize this. It would take too much time, and I know you have other appointments, but I do think we need to look at three basic points that strike me out of this. What I like alliteration. I call it the 3 C's. The first C is complementarity. It's quite clear that if we're going to address the challenges that face us and the opportunities in migration and the health and well-being of migrants, we're going to have to work together in order, first of all, to better understand the health aspects of mobility and the mobility aspects of health. Given what we've faced, we have to develop greater complementarity in our programming. Migration and health are clearly 2 cross-cutting issues that need to be addressed by multiple partnerships. And IOM and WHO are working together on these 2 fields with many other partners. If you take the example, and I'm so grateful to all of the Coast Guards and Navies that are out there, Italy, Malta, the Hellenic Coast Guard, Turkey, and even to a degree the Libyan Coast Guard, which are all trying to help because they're doing some life-saving too. But when I think about Mare Nostrum, which is doing such a great job, they saved a couple 100,000 lives, and we tried to keep the operation going, and somehow it just wasn't possible to bring it together. We have to bring it together, and I'm grateful for all that the new operations are doing. We cannot solve the migrant health challenges by the health sector alone. It has to be integrated into development, foreign policy, security, environmental, and other aspects of the work that our people expect us to do. The second C is compassion. I've been trying to make the point, I don't think anyone's ever quite understood what I was saying, but you will not in the global north resolve the demographic deficit by a compassion deficit toward the global south. We got to get it all together somehow. We got to bring it together so that we change the migration narrative, because in some ways the anti-migrant sentiment has almost become an anti-people sentiment. These are people we're talking about. And so I'm just very pleased that we could have this very frank conversation and hear these experts tell it like it is. For example, what we discovered is most countries don't even keep records of who dies on their borders. So the statistics last year, 3,700 died in the Mediterranean. Who knows? We know that many died. It could have been twice that many, maybe 3 times that many. The result is double jeopardy. Families cannot come to personal closure. The body's never found. And they can't come to legal closure either. Property held in jointly, et cetera, et cetera. I'm diverting a little bit just to show you that it's really all about people. So turning migration challenges into opportunities for everyone requires good migration governance. It means having a broad and durable consensus among a very wide constituency. It means coherent, coordinated policies, particularly in the health sector. I think that we love to place people into categories, certainly also in the field of migrants. It's too simplistic to say that all those who don't qualify for protection under the 51 Convention or the Stateless Convention are all economic migrants. Not true. You have pregnant women on the move, heading to safety and a new life. You have the sick and the elderly, victims of trafficking, Syrians who all they want to do is go north to join their families in Scandinavia. They're already there. We have many others. You have tens of thousands of unaccompanied minors. So all of this, it seems to me, is part of the picture as we try to integrate migrant health into the universal health coverage system. And that brings me to my third point very quickly, comprehensiveness. We've got complementarity, compassion, and comprehensiveness in health care coverage, one that it has to include migrants, universal health coverage. If you take the reaction to Ebola, the attitude of many countries, and including some very close to me, the attitude was twofold. Let's shut down the airwaves and put anyone into quarantine who happens to make it back from Africa. That didn't work, and we had to then ultimately get together and finally try to help the Mana River Union countries to resolve the issue. So I come to a conclusion here, but simply to say thank you very much. This was a technical briefing. I think the first of its kind that's been held at a World Health Assembly. I really want to thank Dr. Margaret Chan, the Distinguished Director General of WHO, and all her colleagues for making this happen. We, as a very modest organization, were delighted and particularly honored to be included in this with one of our most traditional partner, UNHCR, and having our regional director here for Europe, very important. So thank you for that. I do want also to, I see the ambassadors here. I just want to express my appreciation personally and for the organization to Ambassador Sri Lanka for the offer of his government to host the second global consultation on migrant health. This is really a wonderful thing. We're looking forward to this. It'll be jointly organized by WHO and IOM. It'll take place in Colombo in October, I think at a date still to be announced. But I hope that all will be able to attend. That's extremely important because this is a basic human right and an essential component of sustainable development. I'll close with, leave you with one thought. I've said it before, I repeat myself. Migration is not so much an issue to be solved as a human reality to be managed. And a key aspect of that management is to ensure that migrants are included in health planning and health policies. Thank you very much.
Thank you, Ambassador Swing, and I'd encourage you, you've had these cards in front of you. They are not just pretty pictures, although they are very powerful pictures. They are also messages for different parts of the issues that have come up today. Take them with you, talk about them to your friends at the sessions that you're now currently missing. But we'll look forward. I want to thank our team very much for getting this together. It's a collaboration between the emergencies team and the health systems team, but we'll be looking forward to further work on strategies and talking to you again. Thanks very much for coming.